Hello, my name is Dr. Mark Gromski, and I'm Assistant Professor of Medicine at Indiana University Health, Indiana University School of Medicine. I'm here today with Dr. Evan Fogel, Professor of Medicine at the same institution, and my colleague on the ERCP team here at IU. We are very pleased and honored to have been asked by the editorial team of Gastrointestinal Endoscopy to speak to you today discussing our paper entitled Annular Pancreas, Endoscopic and Pancreatographic Findings from a Tertiary Referral ERCP Center. Evan, before we discuss your motivation for pursuing this topic of annular pancreas, or why you felt the need to actually do the study, why don't you tell us a little bit about annular pancreas, as this is a rare entity? And I believe that many of our viewers today may have little experience with annular pancreas. I suspect that many of us may go our entire career without seeing or recognizing a patient with this entity.
Mark, that's a good point. Annular pancreas is a rare congenital anomaly, most often diagnosed in children, but we certainly do see it in adults as well. Basically, it's an entity where pancreatic tissue either partially or completely encircles the duodenum. In kids, this can lead to obstructive symptoms, such as nausea and vomiting or failure to thrive, but there's really little experience in the adult population. Most of the existing literature includes very small case series and case reports. Previously, annular pancreas was felt to be quite rare, as you point out, with estimates of annular pancreas occurring in approximately 1 in 20,000 live births. More recent estimates, however, have suggested that it may be as frequent as 1 in 1,000 births.
So tell us, Evan, why did you decide to pursue this topic if it is quite rare?
That's a good question. Really, this stemmed from my own curiosity after I gained some initial experience with patients with annular pancreas. I remember vividly a case many years ago when I performed an ERCP on a young woman on a weekend when she presented with cholangitis. She previously had been given the diagnosis of annular pancreas based on abnormal imaging, but her ERCP was technically quite difficult. After struggling to get it done, I wondered whether others had experienced similar problems, similar experiences. There was really nothing in the literature to describe endoscopic findings or management of these patients. And even my senior colleagues at IU, Glenn Lehman and Stuart Sherman, had some but limited anecdotal experiences. So I began to collect data, review charts, and our own ERCP database at IU. We didn't have an extensive electronic medical record back then, so this was really quite time-consuming. What I did find was that we actually had a relatively large number of patients who had undergone ERCP at our institution, where annular pancreas had been identified, either at that ERCP or on previous imaging. Why don't you summarize those findings for us, Mark?
Of course. Thanks, Evan. So in this paper, we found that from 1994 to 2016, we identified 46 patients who had undergone ERCP who had annular pancreas identified either prior to that ERCP or at that ERCP. These ERCPs were performed for a variety of indications, mostly pancreatic, but some biliary. Prior foregut surgery was found in 11% of patients. We found that a duodenal narrowing or a duodenal ring was present 85% of the time. However, only 4% of patients had retained gastric contents. ERCP was technically successful in 91% of patients on the first attempt, and the remaining patients had technically successful ERCP on the subsequent endoscopic attempt. Consistent with prior reports of far fewer patients, we found that a significant number of patients, 46%, had concurrent pancreas divisum. Of the 21 patients with pancreas divisum, the location of the minor papilla was reported in 16 of those. And this was found to be quite variable. The minor papilla was located at the junction of the first and second portions of the duodenum, just proximal to the annular ring, on the annular ring itself, just below or distal to the annular ring, or in the usual position, just proximal to the major papilla in the 1 o'clock position. This variable location often made minor papilla cannulation more challenging, and our technical success rate with minor papilla cannulation at the index ERCP was only 86%. We did succeed on a second attempt in the remaining 3 patients. Interestingly, we found that approximately 1/3 of the entire group of 46 patients had pancreatographic findings consistent with chronic pancreatitis on the index ERCP. Since this was a retrospective study encompassing over 20 years of ERCP at a high-volume center, we were not able to collect any meaningful data regarding outcomes from the endoscopic therapy in this group.
Thanks, Mark, for that review. As I see it, this paper illustrates that physicians who perform ERCP may on occasion encounter a patient with annular pancreas, and we should be prepared to deal with a variety of anatomic abnormalities, including prior duodenal-duodenostomy, duodenal narrowing, and a variable location of the minor papilla, as many of these patients have pancreas divisum, and they may be referred for pancreatic or minor papilla therapy. The procedure may be more difficult, but success rates are still very good in expert hands.
Thanks, Evan. That's a nice summary. I'd like to thank you, Evan, for taking the time to discuss this paper with me today, and again to the editorial team at Gastrointestinal Endoscopy for giving us this opportunity.
Thank you, Mark.